Hello again, Peter Nadal. It's my great pleasure to introduce you Mark van de Bogart. Mark van de Bogart is a great nurse from the Netherlands. He has more than 25 years of ICU experience, made his master degree in nursing science in 2005 and his PhD in 2012 about ICU delirium. Now he's a senior researcher in the ICU at the Radboud University Medical Center in Nijmegen in the Netherlands. He published a lot of papers about ICU delirium and other aspects of ICU care. And he is doing a lot of research, actually, and leading master students, PhD students. And my impression is he's always doing research and publishing paper. So I'm a huge fan of him, following on Twitter, for example, and I'm very keen and curious about this session about pain, sedation, and delirium management. Mark, please start.
Thank you, Peter, for this nice introduction, and thank you for listening and watching this presentation about pain, sedation, and delirium management in ICU patients. And we have three learning objectives, and one is why do we need sedatives and analgesics in ICU patients? The use of anago sedation and how this changed ICU practices, and how to recognize delirium and how to prevent and treat ICU delirium. So these learning objectives are connected to the content of my presentation about pain, sedation, and the delirium management. So what do you need to know when entering an ICU as a nurse? First, most ICU patients are critically ill and needs intensive monitoring. Also, one or more organs may fail to function and need support. For instance, to support the patient with breathing and to keep up a good oxygenation in case of respiratory failure or post-operative after major surgery. And those patients need support of the mechanical ventilator, and in that case, the patient is not able to speak because of the endotracheal tube. And in case of heart failure or shock, support of blood pressure increasing drugs like inotropics are necessary. And in case of kidney failure, support with dialysis can be necessary. But important, and in short, patient's situation in the ICU can sometimes be very fragile, and therefore stabilizing the situation is crucial. For the patient, this situation can be very stressful, highly uncomfortable, and painful. And therefore, I'm focusing on the use of analgesics and sedatives and about delirium, which occurs frequently in patients in the ICU while they are critically ill. So this presentation is built up on the pain, agitation, delirium, immobility, and sleep disruption guideline of the American Society of Critical Care Medicine, which was published in 2018. So this is an evidence-based presentation. Starting point while working with critically ill patients is, besides keeping the patient alive, is taking care for the patient's comfort by reducing pain, keeping the patient awake, calm and alert, and not delirious. And from here we start. So alongside the patient's illness, which can result in pain and suffering, also ICU patients are often subject of painful procedures like insertion of lines, tubes, and catheters, but also when turning the patients or wound treatment, and so on. Therefore, all ICU patients will have a kind of analgesia subscribed. And sufficient analgesics will increase patients' mobility in and outside the bed, patients' feelings of comfort, reducing irritation of the tube, and supporting patients' painless breathing. But also, it may reduce traumatic memories regarding painful procedures and such as preventing from post-traumatic stress disorder. But it also can prevent from delirium. So pain management is of utmost importance in the ICU, and the first part is pain assessment. First, regularly assess the patient for pain when the patient is in rest using the numeric rating scale, the NRS, in case if a patient is able to communicate. And ask the patient to score the level of pain in rest. And second, to score the pain level when inhaling deep. So if the patient is not able to communicate for any reason, then use the critical care pain observational tool, the CPOT, or the behavioral pain scale, the BPS. The critical care pain observation tool is a 4-items tool. So observe facial expression of the patient, observe body movements, muscle tension, and the compliance with the ventilator or vocalization in case of the patient is extubated. And for each item, the range is from 0 to 2, so in total 0 to 8 points. And a score above 2 means that the patient is suffering from pain when using the CPOT. The behavioral pain scale, the BPS, is a 3-items tool observing facial expression, the movement of upper limbs, and third, the compliance with the ventilator. And with a score of from 1 to 4 per item. And the score of a 6 or higher, then the patient is suffering from pain when using the BPS. Importantly, both assessment tools are well validated and therefore recommended for use in the ICU. And the starting point of pain management is that a patient does not need to suffer from pain. So not while in rest, but also not during or after a procedure. Use standard treatment of acetaminophen or paracetamol as an adjuvant therapy to opioids. That's important. And the use of an analgesic like opioids and recommended opioids are use of fentanyl, morphine, or remifentanil. But of course, there are more opioids that can be used in the ICU. Important to remember is to increase the dose or bolus of an opioid before any painful procedure. Think of suctioning, line insertion, or wound treatment. Because we want a pain-free and comfortable patient. But remember, increasing the dose of an opioid will also increase will have a sedation effect of the analgesics, so which is also called the anagosedation. Anagosedation can be considered as a side effect of analgesics when increasing the dose, but it can also be used as a treatment effect to have a patient free from pain and in a kind of drowsy state to comfort the patient. The second reason for anagosedation can be the combination of sedatives and analgesics with a high dose of an opioid added with a low dose of sedative, because the less you need the sedation, the better the outcome of the patient. So bringing me to the next topic, which is sedation. Main reason for the use of sedatives in ICU patients is to relieve anxiety, because the ICU environment, but also the situation of critical illness can result in an increased level of anxiety and sometimes also in agitation of the patient. And especially this can be very harmful when the patient's situation is respiratory or hemodynamically or both very unstable. And in those cases, patients are treated with sedatives. And since we are aware that sedatives results in more delirium, prolonged duration of mechanical ventilation, immobility, etc., we nowadays use sedatives less and short as possible. Therefore, the use of anagosedation is often recommended above the use of sedation. And always use sedation in combination with an opioid. Important to mention is then one might think that a patient on sedation is asleep, but that isn't true. This patient is in sedation-induced coma, so the patient doesn't sleep. That's an important thing to remember. Recommended are the use of short-acting sedatives, propofol or dexmedetomidine or Dexmed, above the use of benzodiazepines, like midazolam or lorazepam. because of the short-acting sedatives, have better results on short-term outcomes compared with the benzos. When we need to sedate the patient, the target sedation level is light sedation. This means the patient is easy to awake and is more or less in a drowsy state. In case of a very serious condition, and as we have seen during the COVID-19 crisis, very unstable patients, or when any movement or effort of the patient will worsen patient's situation, in that case, deep sedation can be necessary. Also, when patients are on the mechanical ventilator and are treated in a prone positioning, often deep sedation is needed. And that's what we saw also the case in the COVID-19 ICU patients cases. How do we assess patients' level for sedation? The Richmond Agitation Sedation Scale, the RASS, is worldwide the most used sedation assessment tool, although there are some other well-validated assessment tools like the SAS or the MAS. When the use of sedation is recommended, then the target level of sedation is a RASS -2, -1, which means the patient is in a drowsy or light sedated state. And when deep sedation is necessary, then the target level of sedation is RASS -4, -5. The patient is then in a coma. Important to reduce side effects of sedation and to improve short-term outcome is to daily interrupt or stop the sedation. Then observe what is happening to the patient when the RASS is going down to -2, -3 or -2. And if the situation remains stable, then discuss or consider to permanently stop sedation or continue in a lower dose with target light sedation. And in case of worsening of patient's condition, then restart immediately and target on deep sedation again. In rare cases, deep sedation is not sufficient, especially in the situation when synchronizing patient's breathing with the ventilator is impossible, which can be harmful for the patient, or when the patient is still frequently and serious coughing despite maximum sedation, or when the patient is fighting with the ventilator, and in patients with severe brain damage with a very high brain pressure, then the use of muscle relaxant can be necessary. And when a muscle relaxant is being used, the patient is not able to use any muscle anymore, also not the breathing muscles. So this is really important. So never use a muscle relaxant without sedation. And when patient's condition is improving or stabilized, first stop the muscle relaxant, but continue the sedation. And also remember that using a muscle relaxant will result in muscle weakness, so-called ICU-acquired weakness, which seriously can delay patient's recovery. The use of sedatives does not improve or accelerate patient's recovery. Sedation frequently prolongs patients' stay on the mechanical ventilator, stay in the ICU, but it also hampers patients' mobilization and use of muscles, and therefore increases the chance for muscle weakness. And it also increases patients' risk to develop delirium, affects patients' memory, but also patients' sleep. And in view of these consequences, when sedation is needed, and this is the case in very sick patients, unless use less as possible and use short-acting sedatives like propofol or dexmedetomidine. Stop sedation every day and evaluate if continuation is necessary. And always remember, sedation does not improve patients' sleep. It is just sedation-induced comas what we see. Then part 3 is delirium management. Many of our patients in the ICU develop delirium, and the sicker the patient, the higher the chance that the patient will develop delirium. And when assessing patients correctly, we see that around half of the ICU patients suffer from delirium. But if you don't assess the patient regularly, you miss around 60 to 70% of the delirium cases. So what we see then actually is only the tip of the iceberg. Assessing the patient for delirium is not the only thing. You also need to know the features of delirium. So regarding these features, delirium has an acute onset with altered levels of consciousness and cognitive disturbances like memory problems, hallucinations and delusions, disorientation, etc. And importantly, the features of delirium are fluctuating during the day or during the days. There are two recommended delirium assessment tools for ICU patients. And first is the confusion assessment method for ICU patients, the CAM-ICU, which is a testing tool. And it will take you around 2 to 5 minutes to assess the patient. And we have the intensive care delirium screenings checklist, the ICDSC, which is an observational tool. And of importance, patients' level of consciousness need to be at minimum moderate sedation, so a RASS -3 or lower. And patients in a coma and thus not responding with a RASS -4 or -5 are not accessible at that stage. So each delirium assessment starts with assessing the level of consciousness using the RASS. And if the RASS is different from the previous measurement, then there is a change in the mental status. And this is the first item of the CAM-ICU. If the RASS was similar, then check if the patient's cognitive state is different from home or if this fluctuates during the day. And this is domain 1. The second item is testing patients' attention by the hand squeeze test or using picture recognition test. And third is the altered level of consciousness, and this item is positive if the RASS is not 0. And the last item, item 4, is the disorganized thinking and asking easy questions, simple questions like, does a stone float on water? The CAM-ICU is positive, so the patient is likely delirious when item 1 and 2 and 3 or 4 are positive. And ICUs working with the CAM-ICU will have the different item pictures and the questions all available bedside using plastic cards, or even it can be used on an iPad. And this, what I said, this task is easily to perform in around 2 to max 5 minutes. Then we have the ICDSC, the Intensive Care Delirium Screening Checklist, which consists of 8 observational items, starting with the level of consciousness again, using the RASS, the SAS or the MAS. A normal and wakeful response to RASS is RASS 0, and that gives you 0 points. And every other RASS score is 1 point in the ICDSC. Then we have 6 other observations regarding patients' inattention, disorientation, hallucinations and delusions, psychomotor action, which can be agitated or retarded, inappropriate speech, disturbance in sleep-wake cycle, so awake during the night and sleepy during the day. And the last item is symptoms that are fluctuating during the day again. And every positive score on an item is 1 point. And the total score in the ICDSC above 3 results in a positive ICDSC assessment, which is again an indication that the patient is delirious. A score between 1 and 3 indicates subsyndromal delirium, so not a full-blown delirium, but subsyndromal. So now you know how to assess the ICU patient for delirium. Then the question is, can we prevent ICU delirium? And we know from several studies that the use of prophylactic drugs are not useful. We are not able to prevent ICU delirium with antipsychotics like haloperidol. We need to focus on modifiable risk factors. As previously said, adequate pain treatment is crucial, and also for the delirium prevention. Avoid hypoxia, avoid the use of benzos and sedatives. Furthermore, improve patients' vision and hearing by offering glasses and hearing aid. Reduce noise and alarms, improving patients' sleep, more light during the day and less as possible during the night. Bundle the interventions, procedures that need to be done during the night, and avoid too much sleep during the day and keep the patients awake during the day. And also the role of the family can be crucial, and therefore extending visiting hours, if possible and allowed, can be helpful in reducing the burden of delirium. Another last important issue is early mobilization, and mobilize the patients as soon as possible. This really triggers patient's brain. So it's not only mobilizing patient's limbs, but it also activates patient's brain. I think that we as nurses can make the difference in this. So when the patient is delirious, this does not mean that prevention has failed. Patients in the ICU are sometimes so critically ill that delirium is not preventable, as we have experienced during the COVID-19 crisis, for instance. First rule in delirium treatment, treat the underlying cause, if possible. So adequate pain treatment of hypoxia, reducing the deliriogenic drugs like benzos and sedatives. Until now, there is no evidence that antipsychotics are able to terminate delirium. So we don't use any antipsychotics anymore for delirium treatment. However, when the patient is agitated or suffering seriously from hallucinations or delusions, I'm favoring still to treat this and only this with antipsychotics, till there is evidence that this is also not effective. And lastly, continue all interventions which you used already for prevention, like improving or restoring the sleep-wake cycle, the use of patient glasses and hearing aid, mobilize the patients, avoid the use of physical restraints. And one of the most important things is also in prevention is encourage the family to visit the patient. They know the patient the best and how to handle in several situations of discomfort, anxiety, sleep, relaxation, rest, etc. So dear attending colleagues, hope that this presentation made clear that pain, sedation and delirium are strongly connected, and pain assessment and adequate pain treatment improves patients' comfort, and also the use of sedatives and use less as possible will result in a calm and alert patient with a low risk to develop delirium, and preventing delirium or reducing the symptoms of delirium will also contribute to patients' comfort while in the ICU. If you have any questions regarding this presentation or otherwise, please send me an email, which you can see here. Thank you for your attention.
Great. Thank you very much, Mark, for this excellent introduction to the PEDIS guideline and the management of sedation, pain assessment, and delirium management. Very, very important. I think we have time for a few questions. I know you have to hurry up, but I think for nurses who start working in the ICU, it can be very frightening, strange how to approach to a patient with mechanical ventilation and thinking about sedation. And first question is, when patient really require deep sedation and they are in coma, do they perceive anything? Does it make sense when I'm talking to them? Or is it better to shut my mouth and doing nothing?
So what we normally do is we act like patient is hearing us. So also when the patient is deeply sedated, so with RASS -4, -5, so the patient is in coma, we act normally like as we do normally, and we think that patients are hearing us. And what we sometimes hear from the patients afterwards, that they heard all our conversations. So it's really important to talk to them normally. And what is really important, I think, that it's also that we have to be positive about the patient's recovery. I think that's really important to know for the patient. Despite sorry.
Yeah, that's a really good advice. I appreciate it. And you mentioned the assessment of CPOT or BPS and RUS, CAM, ICU. How often do I have to do this for a single patient?
So when the patient is sedated, what we normally advise is to assess the level of sedation, so using the RUS, the SAS or the MAS every 2 hours. And when the patient is not on sedation, then you can do it only once in a shift, so once in an 8-hour shift, or twice if you have a 12-hour shift. And for pain assessment, it's similar to every 2 hours. And also when the patient is undergoing a procedure or something else, then we also have to do it more frequently.
Yeah, depending on the procedure.
Exactly. And also what was the previous pain score? So for instance, when the pain score was 8 or something, or a CPOT score for 6, and the patient needs some extra opioids, then when you administer the opioids, then we have to reassess 30 minutes later if it's effective or not.
Yeah, makes sense, of course.
Yeah.
When nurses start in the ICU and they have to take care of the patient on mechanical ventilation, it's very important to know, even if they have a light sedation, they are not able to talk. They cannot talk because of the endotracheal tube. How can I talk to a patient with an endotracheal tube, and how can I assess him for the CAM ICU, for example, because he's not able to speak? How can I do this?
So what we normally do is ask closed questions. So that can be answered with yes or no, or nodding, or shaking the head. So just easy questions, so not open questions, because that is really difficult for the patients, and can be very stressful for patient, because he's not able to speak. And he's willing to sometimes, especially the light sedation patient. So it's very crucial to ask simple, easy, closed questions with answering with yes or no.
Yes, makes sense. Thank you.
Okay, welcome.
Thank you very much, Mark. This was a perfect introduction in the management of sedation, pain, and delirium management. And I hope that I'm sure it is a great help for all the nurses and therapists and physicians who are listening and watching this video, and who make further training, continued training on this, I hope, routine assessment in the ICUs. To admit, I know that in Germany, not all ICUs are following your recommendations, but we are more and more who are frequently assessing pain for patients for sedation, pain, and delirium. And I think the situation is improving.
Okay. It was a pleasure to doing so, and wish you all the luck. And also for the nurses who are going to work in the ICU.
Yeah, yes.
Thank you very much.
Thank you very much, Mark.